Thanks for having me here. It's a great privilege. My name is Tom Anders. Um, I'm now a retired child psychiatrist. Uh, I went to college at Stanford University, and I grew up in San Francisco, and I went to college at Stanford University, and I went to Stanford Medical School, and then I went to Boston Children. Well, I did an internship. In those days, we had rotating internships. So I had like 4 months of pediatrics and 4 months of surgery, et cetera. And then I started a pediatric residency at the Boston Children's Hospital. And I got drafted by President John Kennedy, and I spent 2 years in the Air Force as a flight surgeon and as a pediatrician, and decided in the Air Force that pediatrics was not going to be my life's choice, but rather psychiatry. And we can go into that in a little bit later. But I became a child psychiatrist. And I've been a director of pediatric child psychiatry at Stanford. I came back to the Stanford on the faculty, and then I went to Brown University and had a career in academic child psychiatry. I worked at the Truckee Hospital as a medical student on weekends in the afternoons, and I was planning to be a general practitioner. And the doctor that was up there, the GP that was up there, sort of was offering me a job. But in my junior year or my senior year in medical school at Stanford, I met a pediatrician who was a research pediatrician in a laboratory, and I started doing research with him. He was really sort of my first mentor. And we had a publication, and we went off to a pediatric scientific meeting, and I gave a presentation as a senior medical student and thought this was terrific. And so my career changed from becoming a general practitioner in a small Lake Tahoe town to going into pediatrics. When I started my residency in pediatrics, I liked kids right from the beginning. I enjoyed working with kids, and it was a terrific residency. But when I got drafted and I spent 2 years in the Air Force in Tripoli, Libya, which was a hardship post for most people. And it was a base of some 10,000 Air Force personnel and their families. And I was the base pediatrician. And I found that most of the moms, or many of the moms, became depressed over in Libya. And there was a psychiatrist on the base who sort of served as a role model for me. The mothers would bring their kids to the base hospital, but it wasn't really a pediatric problem. It was a behavioral problem, or it was depression in the mom. And I got very interested in the psychiatry aspect of care. You have to remember that this was in the 1960s, and there was a great deal of stigma for medical students going into psychiatry. People would say, you're too smart to go into psychiatry, or you got to be crazy yourself in order to go into psychiatry. And I had swallowed some of these biases as a medical student and as a pediatric resident. Another interesting thing was when I was a pediatric resident at Boston Children's Hospital, and if I ordered a psychiatric consult for one of my kids, the psychiatrists were not very helpful. They didn't really speak the same language as the pediatrician, and they would give these psychodynamic explanations for behavioral problems, and that didn't help me as a pediatrician. But in Libya, I saw this psychiatrist who was very practical and very effective with the moms, and he also worked with kids. And so I decided, serendipitously, if you will, that I wouldn't go back and finish my pediatric residency, but I would start as a psychiatric resident at Columbia. So I did my psychiatric training at Columbia in New York. I had a peculiar career into child psychiatry because I had my pediatric background, my adult psychiatric background, and then my first academic job was on a pediatric consult liaison service. So basically, I never did have a 2-year child psychiatry fellowship. I had lots of pediatric and adult psychiatry and even psychoanalytic training. At Columbia, there was a psychoanalytic institute, and I took that course and became a card-carrying psychoanalyst for a while. When I was at Columbia as a resident, I met my next mentor, who was Howard Rufford, and he had done some basic research in REM sleep. REM sleep was just discovered during those years, and REM sleep was supposed to be dreaming sleep, and psychoanalysts were supposed to be interested in dreams, and Howard Rufford was studying the onset of dreaming in newborn infants. He was looking for the age, the developmental period, the age when REM sleep might appear, and then he would say, oh, infants or young toddlers begin dreaming at that age. But it turns out that newborn infants have more REM sleep than adults have, and he couldn't quite explain why there was so much REM sleep when he didn't know what infants were dreaming about. Anyway, I got interested in, as a resident in his laboratory, and I started doing sleep studies, polygraphic recordings of newborn infants while they were in the nursery while I was a resident. And then when I finished my residency, he had moved over to Albert Einstein, and I took a research fellowship post-residency and developed my own laboratory, got a career development award from NIMH to study the developmental of sleep patterns in human infants. And it was a brand new field, really. And I had my own lab, and I had my own grant, and I was doing my research. When I met my wife, who was a research assistant in Howard's lab, she was working with some of the animal studies, and she wanted to go to medical school. And she ended up taking pre-med courses, post-bac pre-med courses, and got accepted to SUNY Buffalo Medical School. And I was offered a job at SUNY Buffalo as head of child psychiatry. Now, mind you, they had been looking for a head of child psychiatry in Buffalo for over 8 years and couldn't find anybody to move to Buffalo because the pediatrician didn't like the psychoanalysts, and the chairman of the department was a psychoanalyst, and he didn't want someone who was not a psychoanalyst to head his child psychiatry program. So I was a perfect fit because I'd had my pediatrics, I'd had my psychoanalytic training, and even though I wasn't a card-carrying child psychiatrist, they hired me as the head of child psychiatry, and my wife started medical school. And then after 2 years in Buffalo, the opening for the head of child psychiatry at Stanford opened up, and I was asked. I was one of the few people in those days that was doing card-carrying research funded by the NIH. There were very few academic child psychiatrists in the late 60s, early 70s, very few that did research and had CVs with publications. And so I was recruited to go to Stanford to be the head of child psychiatry. Again, not a card-carrying child psychiatrist, and stayed there for 10 years. And while there, I did take my boards. In those days, they would allow you to grandfather in, and I took my boards in child and adolescent psychiatry. I'd already had my boards in adult psychiatry. And so I became a card-carrying child psychiatrist. And I spent my 45-year career as a child psychiatrist in academic medicine, running child psychiatry programs. From Stanford, I went to Brown. From Brown, I went to UC Davis, where I was the chair of the Department of Psychiatry. And then I retired from UC Davis. So I've had a long, distinguished academic career. And I continued my sleep research. It moved from infants, studying REM sleep in infants. It moved to using video cameras to record sleep, and ended up at the UC Davis Mind Institute looking at the sleep in children with autism. So it's been a wonderful career, but it's been largely in academic medicine. I love kids and I love being with kids, and I did a lot of play therapy. Most of my, I would say that most of my clinical work was as an infant psychiatrist, looking at the kinds of problems that parents had with their small infants, toddlers, preschool children, related to behavior, related to sleep problems, related to feeding disorders. We started a feeding clinic at UC Davis, and it was working collaboratively with pediatrics. I spent my time in pediatric consultation, liaison psychiatry. My background in pediatrics gave me a language by which I could communicate with pediatricians. I was one of when we were at Brown, when we moved from Stanford to Brown, we were one of the pilot projects that started the triple board program. And I was very enthusiastic about the triple board program because of its connection to pediatrics and child psychiatry. So this sort of collaborative psychiatry, especially with young infants and families, was what gave me the greatest satisfaction. To some extent, I'm pretty old-fashioned, and I believe I have a lot of faith in my sort of psychodynamic formulation of family dynamics and individual dynamics. And although I think that the purely psychoanalytic approach is no longer current, and that's good, but the thinking that went into sort of developing a relationship with a child. I always said that the difference between a pediatrician and a child psychiatrist is that the pediatrician talks to the family and the child psychiatrist talks to the child. And the child psychiatrist needs to get down on the floor where the child is and be at a level with the child and communicate with the child using tools that the child is familiar with, such as play therapy. So those values have continued to be present in my view of where child psychiatry should go. And this notion that you have a 15-minute med check visit with a child or with a child and family goes counter to my values, even though that's where the field has been lately and maybe there in the future. So personal relationships and an understanding, developing empathy and trust in a relationship is really the core value for me in child psychiatry. So when I went to Buffalo and became the head of child psychiatry, I'd never even heard of ACAP. And the executive director, who now is Heidi Forty, but before Heidi was a woman by the name of Virginia Anthony. Ginger was her name. And Ginger gave me a call when I had taken this new position. She called from her Washington office and she said, "Tom, do you know about ACAP?" And I said, "No, I really don't know anything about ACAP." And she said, "Well, come to one of our meetings." So this was in 1972. I went to the first ACAP meeting, and I was blown away by how friendly it was, how welcoming it was, how exciting the program was, how the staff, Ginger at that time were so friendly and welcoming. And I'd been going to the APA meetings annually, but those were so big and so impersonal. And I felt lost. And when I went to the first ACAP meeting, I felt like I was a part of the group. And it's been my professional home ever since. I served on a number of committees. There was a task force at one point about the future of child psychiatry that the then president, Irv Phillips, had formed. He was the head of child psychiatry at UCSF at the time and the president of ACAP, and he formed this task force. And I was on the subcommittee of what's the research future for academic child psychiatry should be. And there was when Marilyn Benoit was the president, she appointed me to a workforce study group because there's always been too few child psychiatrists, and what could we do to improve the membership and the interest of medical students into child psychiatry. And I was on the education committee for a while because I'd been in an academic setting for my career. And then I was nominated for president, and I served as president with great distinction and privilege of the academy. And that involved, 2 years of pre-president, 2 years of president, and 2 years of past president. So for 6 years, I was on the executive committee and contributed actively to the organization. When one is president, one gets an opportunity to have a presidential initiative. And my presidential initiative was to try to recruit. I used my funds, the funds from the initiative, to pay the tuition of young faculty to become better teachers. And we had a program at the Harvard Macy Institute in Boston over 3 years, where each year 4 to 6 child psychiatrists were supported to participate in this program. And they then have formed this sub-organization or club within the academy for teaching teachers. So that was an initiative that worked out well. When I was the president also serves on the Klingenstein Foundation Scientific Advisory Board. And after my presidential years, I continued on that advisory board. The Klingenstein Medical Student Program, I was very actively involved in that, and also on the review committees for their ADHD and depression fellowship awards. And I continue to be involved with the Klingenstein Foundation program for medical students. So it's been child psychiatry as a profession of practice has been so satisfactory, but as a professional home with peers and working on projects and mentoring young people has been a major part of my professional life. I think the most important activity that one can involve themselves with is finding a mentor. And it doesn't have to be a mentor associated with research. It can be a mentor associated with clinical practice. It can be a mentor associated with teaching. It can be a mentor associated with diversity. But as a fellow in child psychiatry, you feel overwhelmed and lost in the beginning frequently. And finding a mentor, I find to be the most critical. The other piece of advice I would say is leave one's options open. My career would have been very different had I been a general practitioner in Truckee, California, providing care to a local community. And it would have been very different as a pediatrician doing some kind of I was doing renal research at that time. And to be open to opportunity and to allow serendipity to play a major part in your life and not close down options is so important. But to do that in the context of being a mentor, finding a mentor. I mean, ACAP should be closely working with other child-oriented organizations. When I was president, I tried very hard to hold joint meetings with members of the Academy of Pediatrics, with members of community organizations, so that ACAP's reputation as a community-focused institution needs to be spread out there. And yes, one of the best things about child psychiatrists, I think, is the ability to work cross-discipline and interdisciplinary and collaboratively, and using parents as peers. And these are all initiatives that are hugely important for child psychiatry. When I was starting in child psychiatry, there was the Holy Trinity, right? There was the child psychiatrist, the psychologist, and the social worker. The psychologist was limited to testing. The psychiatrist was limited to doing diagnosis and treatment. And the social worker was limited to doing family therapy. Well, we've come a long way in terms of our ability to share. We can be leaders, but we can also share our responsibilities and work collaboratively and cooperatively with a broad spectrum of both professionals and non-professionals. I think we need to be politicians. I think we need to advocate for kids. So we have, I think one of the best advantages of being a child psychiatrist is you have so many opportunities to function in a variety of ways. It's important to have a broad set of interests and identities that that doesn't leave you focused as purely a child psychiatrist and professional. So I am a husband. I am a father of 3 sons. I am a grandfather of 8 grandchildren, ranging in age from 1.5 years to 22 years. I feel that my family, as a family person, I feel that's a very strong identity. And now in retirement, it's even better. I mean, I have a lot more time with my kids and enjoying my grandchildren. I feel like, I mean, I sort of unfortunately have these middle class values. I feel like I like music. I like to travel. I like to be outdoors, and so in those senses, those are parts of me. I guess I identify as a Caucasian male who hasn't had a whole lot of experience with the other racial and gender identities. I respect people as much as I can. But, you know, I'm mostly a family person with interests outside of child psychiatry. But I must admit I was a workaholic, and I enjoyed my work a lot and spent the major part of my my identity as a academic child psychiatrist. The biggest challenge of my career, basically, there are 2. One is that my wife became a pediatric neurologist, and she also spent most of her career, she's now retired as well, she also spent most of her career in academic child neurology. So the biggest challenge was trying to get two people's jobs and moving from one place to another to stay in the academic pipeline. That was really hard. When I was at Brown, I was at Bradley Hospital in Providence, Rhode Island. And I had a lot of challenges there. I was I was the president of a hospital, and it was way over my head. And it was a huge challenge. And finally, I had to leave it. And we moved to UC Davis, and that was very hard for my wife to do. And so raising a family and moving as an academic, which most academics do, is a major challenge. Starting over at a new place. As I mentioned, it was both as a college undergraduate, as a pre-med student, and then as a medical student. At first, I was working in a hospital in the Palo Alto area as an orderly. I wasn't sure I wanted to go into medicine, but then sort of working as an orderly in the hospital on weekends and in evenings, and then working in the hospital in Truckee, convinced me that I could do it and that I liked doing it. And when I saw what this psychiatrist in Tripoli was doing with his patients and really helping them as a family, I became convinced that the choice to be a physician and a psychiatrist and a child psychiatrist was the right one, and I've never regretted it. I came from a sort of middle-class family, and I had to work my way through college, and I didn't. It was hard, but it was worth it, and I don't regret it. People come up to me now and ask, young people who want to be doctors, and they ask me what's my advice about becoming a doctor. And it's hard for me because medicine has changed so much, and it's changing very rapidly. And the burnout that people feel today as a result of the pressures of practice, I never really felt. I know what they're going through now, and I empathize. But for me, medicine was a whole different experience than I think it is for people today. So when people ask me what they should do, I try to explain to them that what I see is the benefits and the downsides. When I was thinking about medicine, no one ever said don't go into it. It was always a very, very positive, well-respected, well-remunerated profession. It just isn't that way anymore. It won't come on its own. You have to be active in pursuing your mentor. So if you find someone that you seem to resonate with and they have a set of interests that are similar to yours, you have to pursue them and ask them whether you can help them and whether they would like to spend time with you or would be able to spend time with you. And it's an active process of the mentee to find the person. And sometimes it doesn't work out and you have to look for a second person, but you have to find one. I think going through medical training without a mentor is really a very lonely, and then you don't know where your future is going. And as I said before, you have to be open to if you like something, pursue it. It may not be what you had originally thought you were going to do, but it'll be all right. So if taking a foreign fellowship and going abroad and working with someone, do it. Follow your heart. The field is open. For one thing, I would say that contrary to what I did, which was to really immerse myself in the profession. I think the important advice today is to have multiple interests that are beyond the profession and don't let the profession overwhelm you. On the other hand, if it's something that you really love and it's fulfilling for you to do, then by all means pursue it. What I'm missing in the field today is the kind of relationships I developed with the families, that I could take time. I could have an hour or 50 minutes or 45 minutes to be with a family, and I could see a family twice a week or once a week for a year and a half or 2 years. And that's so hard these days. And I'm not sure that Zoom meetings bring you the same kind of relationship. I know that they've been very effective, and research shows that the outcomes are acceptable, but I don't know how satisfying that is to the child psychiatrist sitting at a video screen and providing that service. And you need to fulfill yourself in terms of feeling satisfied. And I'm very optimistic about AI, and the technological advances in providing care, but it's a different field, and it may be that different people are being attracted into the field so that they will be satisfied by it. That's fine, but I think someone with the values that I have, and the kinds of experiences and practice and training that I've had feels uncomfortable today. That's the topic of an entirely different conversation in terms of how you contract for a job, and what the requirements of particular jobs are, and how you say no to those jobs or alter the way a contract gets written. I don't know if we have time, but I have a short story of a very famous psychologist who developed one of the ADHD instruments for measuring ADHD, and he was at Harvard. And the chairman of the Department of Psychiatry at the University of Pittsburgh wanted to recruit him to Pittsburgh, and so he went up there and began to negotiate with him. And he said, "I need a laboratory. I need support for 20 people in the laboratory. I need to be a full professor. I need to be titled a director." He gave him a whole list of requirements and a salary that he needed if he was going to leave Harvard and go to Pittsburgh. And the chairman of the department said, "I'll give you all of that. I want you so badly." So he went up to, he gave up his job at Harvard and he went up to Pittsburgh. And the first day that he went to work there, he went into the parking lot and he said, "I'm so and so, and I'd like to park my car." And he said, "Well, I don't have your name on the list." So he went up to the chairman and he said, "You know what? It is my first day. I'm delighted to be here, but I don't have a parking space. They don't have my name on a list of the parking space." And he said, "Well, you didn't ask for that in the contract." And, it's a stupid example, but if you're going to take a job in a large organization, especially, or even in a private practice group, you really have to be very careful about what you want and what they're offering, and make sure that the contract holds true. Well, no, I mean, I retired when I was 70, and I did it. It was hard for me to retire, and retirement itself is a process, and so it took a while for me to sort of feel comfortable without having very much to do after I'd been so busy all my life. Um, but I feel great about it now, and I think if one is thinking of quitting while they're young and because they're burned out and I was talking to someone just yesterday who took a year off and did something else and then came back to it. Uh, there's all kinds of ways to accommodate or to adapt to the kinds of pressures. I think in today's day, as I've said it before to you, you just need a set of interests that keep you away and give you other satisfaction. Hugely important, and basically that's what ACAP does. There are other ways to network and local, regional organizations and staying active, but uh, but ACAP is really a wonderful networking place, and I think most people appreciate ACAP for that. I think the satisfaction rate of members of ACAP is very, very high. And there's always a committee of some kind that meets some interest of an individual, meets the interest of an individual. And I think there's always members, both senior and junior colleagues at the same level, and senior members who want to be mentors. Anybody who wants a mentor can find one. It's hard for an old timer like me who looked at a field that was different from what it is today to offer advice to young people whose career goals may be very different, whose skills and technological um, skills may be very different. So it's really hard to offer advice, but I think I have faith that the profession itself grows and will encompass and support and be available to the people coming up through it. And so I'm not opposed to change. Um, and as it changes, I hope that people will continue to feel good about being child psychiatrists and will continue to provide services that are helpful to children and their families. And I think hopefully they will continue to be collaborative and interdisciplinary. I mean, those are all good things that have been happening. The silos of the 60s, I think, are going away. The stigma of the 60s and 70s is being significantly reduced. And I think the treatments, psychopharmacological treatments, are an improvement. They're not a cure by a long shot, but they're an improvement. I think we're going to have to make more improvements in our diagnostic DSM-5 as well. We're not there yet, but people are working on it. So I'm optimistic. For me, as a medical student, not exactly knowing where I was going to end up, I ended up in the right place. And I feel a tremendous amount of gratitude to my patients and to my colleagues and to my mentors.